All right, good morning, everyone. Good morning and welcome to Palliative Care and Geriatrics Grand Rounds. Welcome to all those here in the Ether Dome, at Care Dimensions, Cooley Dickinson, and at Dana-Farber. I'm B.R. Daubman, the course director, and it's my pleasure to introduce our guest speaker this morning. Dr. Keren Ladin is an assistant professor at Tufts University and the director of research on aging, ethics, and community health at Tufts University. She received her Bachelor of Arts in History and Philosophy of Social Science and Medicine at the University of Chicago, her MSc in Population Health from the Harvard School of Public Health, and her PhD in Health Policy from Harvard University. Dr. Ladin teaches courses in health policy, research methods, public health ethics, health disparities, and medical ethics. She incorporates quantitative, qualitative, and normative approaches to study how systemic disadvantages affect health and the ability of individuals to make and pursue life plans. Specifically, her research examines socioeconomic and racial disparities in transplantation, mental health treatment, aging, and immigrant health. She aims to better understand how social networks impact health disparities, acute medical decision-making, and resilience in major life transitions. Dr. Ladin is also the director of the Lab for Research on Ethics, Aging, and Community Health, the REACH Lab, at Tufts University. Please join me in welcoming Dr. Ladin.
Thanks so much. It's such a pleasure to be here. It's such a unique venue and audience, so I really appreciate it. I'm going to talk a little bit today about some of the work we've been doing over the past few years looking at dialysis decision-making amongst older adults. I'll present a little bit of the work that we've done in our lab, and then move to talk about a randomized control trial that we're doing now, testing a decision aid to help older adults make more preference concordant decisions. And I welcome any thoughts, comments along the way or at the end. So the objectives today are just to understand the growing need for increasing palliative care and innovative decision support for older patients who are facing dialysis decisions, to compare 4 common approaches for dialysis decision-making among older adults, specifically in how nephrologists present their options, and to identify opportunities and models for collaboration with nephrologists to improve this area of decision-making. I have no relationships with any industry pertaining to this presentation. And just a brief thanks to our funders, PCORI, the National Center for Advancing Translational Science, and the Greenwall Foundation. So I'll start just by talking a little bit about some of the recent literature demonstrating the very difficult decisions that are facing older adults with advanced kidney disease, and especially focus on the potential for low-value care around dialysis in this older population with significant comorbidities. Then I'll turn to talking a little bit about barriers and facilitators to conservative management. By conservative management, I mean medical non-dialysis management for older adults. And then I'll talk a little bit about our DART trial, our decision aid for renal therapy, and how we're trying to promote autonomy and engage patients more in their decision-making process, especially patients with limited health literacy and patients of underserved backgrounds. So in nephrology, I think that there has been a shift in recent years to identify that patients care not only about extending their life, but also the quality of their life, especially towards the end. And this is from the NKF president, Jeff Burns, who said patients care about quality of life above all else. And there have been many studies in recent years demonstrating this among nephrology patients. But he says, but too often healthcare providers and family members are focused on mortality. And we see this. So despite kind of increased attention to quality of life, we don't see any differences in trends for conservative management or even talking about quality of life within these decision-making appointments. Just a brief background. So kidney disease is there's a growing burden of kidney disease among the elderly worldwide, and especially within the U.S. In the U.S., CKD is the 9th leading cause of death. There are dramatic increases in the population over age 75 with kidney failure who are facing dialysis decisions. And in fact, this over 75 population is the fastest growing dialysis population in the country. So dialysis involves significant healthcare interventions and has significant quality of life trade-offs. And yet the benefit, especially for older patients with comorbidities, remains questionable. There's not a lot of great evidence from the US because conservative management is seldom done, and there's a lot of selection, but evidence from outside the US suggests that there are survival benefits, but they may be marginal. Moreover, it's unclear that patients really understand that they have a choice, that they're choosing between medical management, non-intervention, and different types of dialysis, or in some cases, transplant. This data here is from a study from Canada of nearly 600 patients. And what they've shown here is that 61% of patients regretted their decision to start dialysis. This study was the first to show that, but there have been many studies that echo these findings. Moreover, fewer than 10% of patients reported discussing end-of-life care with their nephrologist, although many of them are reliant on their nephrologist for managing symptoms, for their advanced care planning, and for psychosocial support. Patients in general in this study and in others have had limited knowledge of palliative care and other options, and it's unclear why they don't understand or are not aware of conservative management. Is it that they're not being told about it? Is it that they're not internalizing this option? What exactly is going on? Nonetheless, the choice to initiate dialysis at later years is significant and has significant implications for the quality and the intensity of care at the very end of life. So what you can see here is that compared to cancer patients and heart failure patients, among Medicare beneficiaries, dialysis patients were more likely to be hospitalized. They had almost twice as many days hospitalized in their final month of life. Their ICU admission rate was almost double that of cancer patients and much higher than heart failure patients. And their use of hospice was about half that of cancer patients. So still a lot of area for growth and opportunity for improvement in these very sick patients. As I said, there's not a lot of evidence around conservative management compared head-to-head with dialysis in terms of survival benefit. This is a recent study looking at veterans using VA data. And what they show here is that there's an increased survival for patients who initiate dialysis if they have relatively good levels of kidney function, but among patients with poor kidney function, there's actually not necessarily a great survival benefit. However, what is clearer is that there are quality of life limitations for everyone who starts dialysis, and this is especially true for patients who don't receive the survival benefit. So dialysis is associated with significant functional decline and cognitive decline. The study on the left shows that the majority of elderly nursing home residents have died or have lost function within 12 months of dialysis initiation. And the second figure shows that more than 30% of patients aged 80 years or older have had significant functional loss within 6 months of initiating dialysis. Outside of the US, dialysis for older adults is not necessarily considered ordinary care. So you can see for younger cohorts, so here ages 45 to 50, 54, 55 to 64, and 65 to 74, there's approximately similar rates of dialysis initiation. And you can see that there's a very steep drop-off after age 75 for countries outside of the US, which raises, I think, very important questions around whether or not this is a preference-sensitive decision. Are people here preferring to start dialysis?
Oh, yeah, it just came up on the screen just now.
Sorry? Oh, okay. Welcome. So you know, I think it's an important question. I think on the policy side, we are loath to take away options that people truly want. The question here, I think, based on this data, is are we exceptional in this case, different from other countries in that more people want interventions at the end of life, or does this reflect some kind of institutional or other types of barriers to decision making that kind of funnel people into a given decision? And that's really kind of what we're seeking to understand. So, as patients walk through these decisions, as their kidney function declines, how do they choose? What kind of inputs do they want? What kind of inputs are they getting? And ultimately, what accounts for the differences that we're seeing between the countries? So the crux of the issue here, I think, is that we can't perfectly predict who is going to do well on dialysis. And we can't perfectly predict when people need dialysis. And so given that, I think the question is, what should we aspire to? And I think in our research, we've kind of come around to thinking that the best that we can do is to really help people make an informed choice and an engaged choice, one that they are satisfied with, and then to provide the best care that we can once they've made a choice. But I look forward to your thoughts on that as well. So as in sum, so the perceived problems around dialysis decision-making for older adults are a perceived lack of choice among patients, and I'll show you some of the data that we've published on that, and very limited health literacy, specifically around end-of-life terminology. So not understanding the term prognosis, not understanding the term intervention. In fact, when we had asked people about their understanding of these terms, many patients were really reticent and kind of put off by the term intervention, and explained to us that it was really reserved for people with addiction problems or people who were overweight. A lot of this kind of culture infiltrating the way that we use kind of common terms, which leads to confusion, distrust, et cetera. On the nephrologist side, I'll show you some evidence to demonstrate the reluctance amongst nephrologists to discuss conservative management and institutional barriers to really following a conservative management pathway. And ultimately, this leads to patients who are dissatisfied with their care. They regret their choices, and they're receiving very expensive and very invasive care at the end of life that's not aligned with their preferences. So this figure demonstrates kind of two different pathways based on the themes that have come out from patient interviews that we did in 2 clinics in Boston. And you can see at the top, really having a perceived choice and being engaged in your decision making, discussing your decision with others, and making an informed decision, being informed about the implications of your choice for quality of life. Patients were more satisfied, and they spoke more highly of, even when their dialysis process was difficult. However, most of the patients that we interviewed fell into kind of this bottom pathway where they didn't perceive a choice. They really struggled around autonomy. They deferred to others, especially their physicians or their adult children, in their decisions. And they described their life as kind of an attempt to be a good patient, to come in on time, to manage their diet and all of these things. And overall, they were fairly dissatisfied with their choice. So instead of this kind of nice picture of 2 different options where you can kind of choose where you're walking along, what we saw is really a funneling to one option and just a complete completely unaware of this other option that might be available to them. So patients told us things like, meaning diet, it was the only way, meaning to survive. It was the only way to go on dialysis. That was it, or I was going to die. So just to kind of give some context here, we only spoke with patients who were 65 and over, and most of them were in their 80s and 90s. This woman said, they told me if I didn't have it, dialysis, I'd be dead by morning time, so I agreed. Doctors said I needed treatment, so I had no choice. I was told to go on dialysis. That was it. I had to do it. There were no ifs, ands, or buts about it. So it's not a picture of people who are understanding that medical management may be a viable option for them. So patients that said this is kind of how they're describing their process of decision making. So again, they're thinking they don't really have another option, or that it's not their choice, it's their physician's choice. So one said, I thought, I don't want to do this. Excuse me, I do not want to do this. I was quite upset. I thought, I'm never going to do this. This was a woman in her mid-80s who was on dialysis. Another said, I really didn't want it, but the nephrologist said so. And this last quote here, they said, they had a very hard time convincing me to take it. I finally did agree, and that's it, because I wasn't well. They kept after me, which I think is a really important kind of feature of the patient experience, right? Which is to say, what is that balance? Dialysis, we don't know when somebody is going to need dialysis, so it's not this binary shared decision-making that we have or can have around surgery with a discrete time point. Instead, it's this long progression. And I think there is this complex question of, when is enough enough? Like, when have you asked somebody enough times that you're confident that their decision is no? Other patients said, the kidney doctor is the one that said I should have dialysis, and I don't know. Lying on a bed 3 hours a day is not my way of living. So these are patients who were not engaged in their decision-making process, reflecting on their current state, right? Whether they were satisfied or dissatisfied. A different perspective is this patient who was on peritoneal dialysis who said, I chose peritoneal dialysis. I don't need to go to the hospital every time, so it's at home. It's convenient for me. I think it's the right decision because you don't need to spend a long time at the hospital. So I think, there's wide agreement. Dialysis is a difficult treatment, and yet there are people who are very satisfied with their choices. And I think our question is, how do we get there? How do we get more of those people? Kind of being fairly agnostic about what choice they're actually making. So to reiterate, kind of the themes that came out of our patient discussions were around lack of choice or lack of a perceived choice, no discussion of prognosis. So sadly, several of the patients we spoke to, when we asked them, what do you think dialysis is doing for you? They said that they think it's curative, that they might be on it for a little while. They said that it's fixing their kidneys, so kind of not understanding what actually is going on. Very limited patient engagement in decisions, and very limited literacy specifically around the terms that are used to describe the decision or dialysis, right? So I think that this kind of reflects and may explain some of the disconnect between the patient experience and the nephrologist experience, which is to say that the nephrologists believe that they are talking about it and the patients are not hearing it. So to turn for a moment to the nephrologist side, after we had realized we were asking the wrong question, we shouldn't be asking, why are you choosing dialysis versus conservative management? We should ask, do you know you have a choice? We turned to nephrologists to ask, how do they decide? There's a variation in how people approach this discussion. How are people approaching this discussion, and what would make a nephrologist decide to describe conservative management versus nephrologists that choose not to. So we interviewed 35 nephrologists in 18 practices across the US. We conducted semi-structured interviews with them, and then we analyzed the data using typological and thematic approaches. And 5 main themes distinguished between the different types of approaches. So 4 approaches emerged, and they differed on these 5 factors. So one was how important is patient autonomy? Is patient autonomy really important in a decision-making process? The second is around engagement and deliberation. How important is the patient as part of the decision-making process? The third factor that really influenced decisions was around institutional norms. What happens at your center? What do your colleagues do? And are they going to respect your decision if you recommended conservative management? Or if a patient comes in emergently, will they wind up on dialysis anyway? How important are outcomes to you? And by that, I mean people really differed in what they thought the outcome should be. What should we be looking at? And finally, I think nephrologists really struggled with what is their role. Is their role to provide dialysis and to help people make that very difficult decision, or is their role to align patients with their preferences? And I'll just show you very briefly these 4 different approaches and the way that these factors shape their decision to either describe or not describe conservative management. So first, there was the traditional paternalist approach. And paternalists strongly identified as patient stewards or protectors of the patient. And they assumed the responsibility for identifying the treatment that was most likely to improve the patient's symptoms. And they viewed patient autonomy and the solicitation of patient values as less important than improving patient health and active treatment selection. Many believed that delegating the decision to patients was an abdication of their duty. And so that they really saw that it would be easier to give it to the patient, but that would be abdicating their duty as a physician. And typically paternalists tailored their discussions to highlight their favored outcome. So one said, where I feel that dialysis would not be an imposition, I present it in a light that they would come away thinking that they need it. Right? So really, and I want to stress, this is not ill-intentioned, right? The idea is that many of these physicians would describe to us kind of the difficulty of seeing patients who they believe would really benefit from dialysis, right? And there was this pervasive belief that, although they knew the numbers very well about quality of life and survival, they had a very strong belief that their patients did better than average. So they said things like that. It's usually my decision in conjunction with them. You have to be the parent and say, listen, I'm sorry, you have to do this. Another one really focused on kind of how you define success and said a successful discussion tends to be one where people consider the option and make a decision about what kind of active treatment they want. So not at all focused on conservative management. And continued, he said, rather than opting for no treatment and a peaceful death at home. Right? So there's this real belief that, when you have this treatment such as dialysis, it could help people and you want to be the one to make that decision and help them get there. I'm just going to skip over this in the interest of time, but there was this prevailing idea that, not actively promoting dialysis was really taking away people's hope. And so one said, I view myself as someone who tries to provide a ray of hope for people who are sick. I've seen enough people who feel so much better and say, what the hell did I wait so long for? Right? So this kind of saliency of the good outcomes really driving their approach. And this is really interesting because it reflected a very similar sentiment that the patient experienced, where one nephrologist said to us, you just develop a rapport and you just know. We were asking about how do they know that the patient should receive dialysis. And he said, if it's like to the point where I was like, no, this is bad. You're going now, no ifs, ands, or buts, done, right? So a real different approach, not really pursuant to shared decision-making, but still guided by this idea that, it's your role to help people make that very difficult decision. And once they make it, they will feel better. A very different approach was something we called the informative approach. And here, really, nephrologists followed the role as an educator and enabled patient-led decision-making. So these nephrologists were very concerned about patient autonomy and that more than that patients pursue a specific treatment. And to accomplish this, the nephrologist typically presented all of the options very neutrally and did not make recommendations about treatment, and they accepted the patient's choices. And they often raised conservative management as a viable alternative to dialysis. So one said, I have not met anyone who has said that they are not willing to make or that they don't want to make a decision about their own life. Another said, I see my role as being the information broker and to provide that information so that if patients walk away understanding at least the basic elements, even if they're in denial, then I guess that's okay, right? And so what really distinguished these clinicians is that they were not adamant about a particular treatment, but they also didn't make a treatment recommendation. So they kind of gave patients information and waited for them to do something with it. So one said there are times that patients are not willing to make a decision, and as a patient, they have a right to really not make a decision because that's their life. And if they do not want to decide what they want to do and ESRD is imminent, they can do that. So there's a lot of respect for patient autonomy, patient engagement, and the patient perspective on timing. The informative approach, they were least likely to judge the success of a discussion based on a clinical outcome. So in contrast to paternalists, and they were really focused on patients understanding what was right for them and what so one said the best are right for themselves, that lets them enjoy and live it with dignity. And what was interesting about these clinicians is that many of them described, we asked them kind of, how did you get to this approach? How did you evolve to this point where you're using this approach? And many of them described a really bad outcome. So a patient who had significant regret or such things, and they've kind of come away from making specific recommendations. And the interpretive approach was where a nephrologist perceived the role as a guide. So they gave information and they steered patients toward an option that aligned with the preferences that the patient voiced. So one said, I think ideally in a perfect world, patients don't make decisions. Patients very clearly articulate their values, goals, and wishes, and physicians are able to achieve the goals, values, and wishes of the patient through the vast opportunities that we have in medicine. Another said it's hard for patients to articulate what specific medicine they want. And I think that couldn't be truer based on our experiences with these older patients. So tell me what your goals are, and I'll tell you what the best way of achieving them is. Developing a kind of knowledge of the patient's wishes and appreciation of their goals such that you can really orchestrate, right? And it's actually this approach where you do make a recommendation that was most aligned with shared decision making, right? So we went back and looked at kind of shared decision making, values and goals, and this kind of role where you see yourself as a navigator or a guide, orchestrating the patient's care was really most consistent. And they really judged the success of the conversations with patients around social emotional factors, right? That there's consensus among the family and that patients feel and understand that they're mortal, they're at peace with their decision, and that the role of the nephrologist is really kind of getting them there. Finally, there was this institutionalist approach, which was an approach that was strongly shaped by the culture of care at the specific practice. And these nephrologists were really focused on kind of the financial viability of conservative management as a pathway, or what would happen if they did not recommend patients for their practice and for the patients themselves. They didn't know exactly what that would look like. How often would they see them? How would that work within their team? And they discussed lack of support. So not being connected with palliative care, with social work, with the other types of resources and support services that, that older patients may need. And you can see here, many of them were concerned about time, right? That this takes time. These are really complicated decisions that unravel over a long period of time that are somewhat unpredictable and uncertain, and they were not sure how to approach that. Some were worried about the emotional backlash from patients. So one said, I think that patients are always sort of suspicious of physicians. I think that patients want to get as much as they can out of the medical care. And when a physician says dialysis may not be right for you, they don't believe that. So this is a person who has felt burned, right? Has tried to describe conservative management and then felt like patients thought they were withholding care, right? So again, kind of the importance of communication and how do we improve that? This question around prognosis, right? This is very common. So this nephrologist said, I don't know the answer to prognosis questions. I think it's either something I do badly, but I actually don't address prognosis. And this was so common. I think we had, maybe 10% of people who really addressed prognosis. I'm raising the institutional barriers, especially in this group, because I think that there's such a room for growth and opportunity for partnership with nephrology services around care coordination and around training and having these difficult conversations. I'll show you kind of what we're doing on our side with patients, but I think that there's a lot of room for interventions also with the clinician side. Finally, I think that nephrologists had a very hard time overcoming this idea that conservative management was no care. And they have very deep and well-established relationships with their patients for the most part. And they describe this kind of thing, right? One says it sort of feels like you're not going to do dialysis, or I'm not going to do dialysis, and that sort of feels like giving up, right? And that's a really real consideration, I think, among nephrologists. And I think we need to think as a community about how to get people to thinking of conservative management, maybe retitling it as active medical management or something like that, where you're providing something, right? And it's clear what you're going to get. You're going to get supportive services. You're going to still be able to see your patients and all of this. I'm going to just skip ahead and just show, in the interest of time here, that you can see that among the nephrologists that we spoke to, conservative management was routinely integrated in 37% of the respondents. And the respondents who did routinely integrate conservative management defined their role very differently than nephrologists that didn't. They were focused on facilitating patient-centered decision-making and adopting patient preferences, right, and accepting them. They viewed conservative management as something, right, as a therapeutic option to promoting quality of life. And for these patients, for these clinicians, I haven't spent much time talking about the moral distress, but moral distress among nephrologists is real, and it's striking. And what we found in our study is that actually those that routinely discuss conservative management as an option, it helped them cope. They described it helping them cope with their distress, right? The onus is not on them to select the perfect treatment. It's on the patient. And because they routinely describe the spectrum of options, they kind of take themselves out of having to make that very fraught decision. This is an example of a conservative management pathway. And these are becoming more and more common outside of the U.S. They are, I think, becoming more common in the U.S. as well, just slower. But I think it's an area of important growth, and one that, I think partnering with palliative medicine can really help improve. And before I kind of come to the end, I just want to skip ahead and show you what we're working on now. So I think that there's been a lot of research around the positive outcomes associated with communication, better symptom management, aligning patient preferences with treatment, better quality of life and knowledge, and improved outcomes for caregivers, and potentially lower costs of care. What we're doing now is we've designed a decision aid together with a company, ME, which was recently acquired by Wolters Kluwer, which is really focused on older adults, on their preferences and their treatment options. And I'm going to show you just a very brief clip. This clip comes at the end of about 40 minutes of different modules describing both kidney disease and what it is, and then each option, including prognosis, right, and showing what the prognosis and what the quality of life implications are.
All right, we've gone over all the treatment options for kidney failure, and I know that was a lot. So let's quickly review and put it all together so you can compare the options next to each other. There's peritoneal dialysis, hemodialysis, which can also be done at home, or home hemo, transplant, and medical management. And just so you know, no matter what treatment you choose, you can ask about getting comfort care or palliative care. With this, you'll have a team of medical professionals to help you feel better and take care of any pain or other problems like depression. That way, your kidney team can focus on taking care of your kidney failure. This can be a huge help to you and your family, and understanding what palliative care can do will help you decide if and when you want to take advantage of it. All right, the best treatment for you, of course, depends on what you want. And so there's really a couple of decisions to make. The first one you'll have to make is whether you want medical management or another treatment, some kind of dialysis, or for some people who are healthy enough, a transplant. So think back to the things that are most important to you, your main goal for treatment, and about anything you'd want to avoid. Some people choose medical management so they can spend more time with friends and family and less time on treatments and continue doing the things they really love. But it may also mean they could die sooner. Others choose dialysis or a transplant. This usually means spending time on treatments or surgery, but may allow them to live longer. I'll focus on dialysis here, since that's what most people who decide they don't want medical management will do. Okay, if you decide on dialysis, the next decision is choosing a type of dialysis. The best treatment option for you will probably be based on some other things too. Whether or not you'll be able to take care of yourself, do things like shower and make meals matters. You can talk to your doctor about these things. He can also talk to you about what you might be able to expect moving forward, called your prognosis. Okay, let's talk a little more about cost. Paying for treatment isn't something people usually have to think about when making a decision. That's because with kidney failure, insurance, like Medicare, usually covers the cost of most treatments and supplies, but each insurance is different. And just so you know, your doctor or a social worker can help you get insurance and figure out how to get the most coverage. So be sure to talk to them about this. All right, the treatment you decide on can really change how you live your life. So think about what's important to you. These could be things like whether you're able to go to a dialysis center a few times a week, or do treatments at home exactly the way your doctor and nurse shows you. Or things like whether you're looking to live the longest or have the best quality of life. Again, that's the flexibility to do the things you want. Let's run through the main points of each option so you can start to figure out which treatment might be right for you. All right.
So that's kind of a summary that comes at the end of this whole first piece. And so just want to spend a few minutes talking to you guys about the DART trial, which is a randomized control trial funded by PCORI. And it's a trial where we're testing this decision aid head-to-head compared to otherwise offered in-person education. So that might be dialysis options classes, one-on-one, whatever is provided at the center. And the goal of the trial is to understand if a web-based decision aid that patients can access in the comfort of their home as many times or as few as they want can help align their preferences for treatment with the care that they actually receive. We're recruiting 400 patients and 250 caregivers who are 75 and older and approaching kidney failure, so CKD stages 4 or 5. Our sites currently are Tufts Medical Center, Maine Medical Center, Northwestern, and UCSD in the San Diego VA. And we've had the pleasure of working with a terrific stakeholder advisory board that has kind of really helped us think about what outcomes we should look at, tailor our decision aid, and they're listed here: the National Kidney Foundation, AARP, CMS, many community partners, patients, care partners, and several medical specialties are represented. The aims of our study are kind of twofold. The first is a qualitative, longitudinal qualitative study, trying to answer the question about how communication and different types of communication can help people or not in choosing their treatment, and especially looking at preference stability. So something that we don't know is how frequently people change their mind about what they want and what's important to them. The second two aims are based on this randomized clinical trial, and they are really focused on patient-centered outcomes, including decisional conflict and knowledge, so lowering the uncertainty that people feel around their decision, assessing whether it affects advanced care planning, completion of advanced directives, and finally, because we are recruiting dyads, so patient-caregiver pairs, we're really interested in the ability of caregivers to predict what patients want, and we're following patients and their caregivers for 18 months. So many of them will experience a dialysis decision, and some of them may die during the course of our study. And so we're assessing also bereavement outcomes among care partners. So I have a little bit more to show you in terms of the decision aid, I guess what I can do is just to say that the decision aid essentially guides people through the different treatment options, very tailored on older adults, and then it asks them a set of questions about them, what's important to them, and asks them to think about the types of activities that are important to them, how much they are willing or want to avoid surgery, how much they're willing or want to avoid hospitalization, how engaged do they want to be in their decision, from not at all, and they want their doctor to make a decision, to very engaged in their decision. And at the end, the goal of this decision aid is not to tell people what they should do, but instead, it allows patients to record their thoughts, their feelings, and it prints out the preferences. And that's actually given to them and to their physician during their clinical encounter to try to help them engage and make sure that they have their questions answered.
First.
So I'll skip that, and I'll just end here with a quote from Art Buchwald, who said, he was a writer and a journalist who was writing about his decision not to pursue dialysis. And here he is writing at the very end of his life about the decision to go on hospice. And he said, "The more publicity I got, the more attention my kidneys got. And instead of going quietly into the night, I was holding news conferences every day. The mail poured in. People were pleased that I had made my own choice. The letters and emails were in the thousands. At the same time, friends came to the hospice to say goodbye. Everyone felt that they should make the pilgrimage. They came with flowers, cheesecake, and corned beef sandwiches. And since I was expected to die soon, the French ambassador gave me the literary equivalent of the Legion of Honor. And because of the publicity I've gotten, the National Hospice Association made me the Man of the Year. I never realized dying was so much fun." And ultimately, you know, it's not fun for everyone. It's a difficult choice, but I think where we are without better prognosticability is just the ability to hand this choice over to patients and hope that they're able to engage and be aware of their options. Thank you.
Thank you so much, Dr. Ladin. I have learned a lot, and particularly I will never use the word intervention again, I think. I have a lot of questions. I want to open it up to the group. Maybe first I'll just ask, I'm so curious about that video, and thank you for showing us. And I wonder how you preface that with patients. I could see a patient watching it at home and saying, I've decided I want a transplant, and then the nephrologist having to be like, ooh, you're actually not eligible for that. So I'm wondering if it's tailored at all.
Yeah, it's a great question. Yes, we spent a lot of time tailoring and pre-testing and going over cognitive testing with patients around kind of how they want the decision described and what they think it means when it's described in a certain way. Especially the transplant module, we really agonized over whether we even include it because so few patients are eligible. But in discussions with CMS and with clinicians, they really felt it was important to keep it in. And so what we did is actually most of the education literature and educational videos spend a lot of time on transplant, a lot of time on hemodialysis, and very little time on anything else. And so patients walk away thinking like, these are my two options. And so what we did is we pared down the information about transplant and we talk about it and we say, for most people in your situation, this may not be an option because you have to be healthy, you can't have these types of comorbidities, and we talk about the eligibility criteria. But we tell them, if this is something you're really interested in, you should talk to your provider about it and ask about it. And at the end, in the section where it's really tailored to their individual preferences, we ask them, what are you leaning to? Right, and so they bring that in and they can talk about that, right? And we haven't seen that most of them press on transplant, but I think, yeah, I think it's a really good question about kind of how do you strike the balance between transparency and not giving kind of false hope. Yeah.
Fascinating tool. Let me open it up to other questions.
So I think you've done some really thoughtful work in terms of thinking about the clinician factors and the patient factors, which I think is super helpful. You know, piggybacking on that question a little bit, I'm almost thinking about the way things are presented almost from a like decision-making behavioral economics perspective. Like if transplant, if you list, people gravitate toward often what they think is middle ground, right? And which I wonder whether how you think about that with because that is a very complex set of decisions that you're offering. And so I guess that's one question I have. Another is, how do you talk about quality of life for those who choose hemodialysis or dialysis in some form versus conservative management? And how to help them think about it. And then, this is like terrible because I'm asking 3 questions, it seems to me in your initial work, it was really clear that kind of what I consider not a typical shared decision-making model, but eliciting goals and values and then making a recommendation actually most strongly supported a shared decision-making model. And how does that happen in this setting? Because you're helping elicit goals and values, but there isn't really a way that there's a recommendation made.
Yeah.
Sorry.
Great question. Okay, I'm going to take the last one first. So generally, the way that so we struggled, and we think that in general, it's not our role to make a recommendation, right? There's so much unknown that goes on with the patient. We don't know their exact medical history. It's not that tailored, right? It's only towards older adults with a comorbidity. And so what we do is we tell them based on the preferences that you've input. So based on how much you want to avoid surgery or how important it is for you to be at home, these are the types of treatments that may align with your preferences. And then we print out information about those treatments for them, along with the questions, like recommended questions that you should ask your provider. And so I think our hope with the decision aid, honestly, is to get them thinking about the types of treatments that might align with their preferences and then trying to get a specific recommendation. So ask them questions. Ask your provider, how should you weigh home hemodialysis compared to peritoneal dialysis or something like that? Gosh, and now I've forgotten the first 2.
The behavioral economics question of
the framing effects.
Right, the framing.
Yeah. So what we did actually in our cognitive testing is we moved around the order of the options in the video. And I'm trying to see if this is going to get to the spectrum of choices. I think that's on a different clip that I didn't include. But essentially, we did move around the options, and what we saw that was affecting people most was the length and the amount of detail that was provided for each option. But in the video, because you can skip around, it didn't seem to matter that much which order you hear them in.
And what about the number, just the sheer number, and anchoring toward the middle, which seems like neither super aggressive or super conservative?
Yeah, I think that's a real concern. And I think the only response that we can have to that is really to try to get people to ask different questions of your treatment, right? So what is your treatment doing for you? Instead of like, where on the spectrum of intervention is this? How invasive is it? Yeah.
And the second question was just, how do you talk about quality of life for those who choose conservative management versus dialysis?
Yeah. So we try to be pretty balanced. With dialysis, we talk about kind of that some people feel good for a few days on dialysis, but then generally feel not so great other days, that it takes up a significant amount of time, and then that it might have implications for social participation, for travel, for things like that, although that it's possible, of course. And for conservative management, we're really upfront. We say for a lot of people, this allows you to do the types of things that you might want to do now. However, your symptoms might increase, right? And so at some point, you may need to address your symptoms. So I think it's a balance, but I'm happy to share the program. Yeah.
Other questions?
Thank you. This is just very intriguing, and I greatly want to follow your work. I think that you greatly highlighted the human part of this treatment and of this disease state, which is not uncommon to other organ failures like heart failure. Liver failure, we don't exactly have such a treatment that we can offer. But I think it's amazing the the integrated approach, because you're kind of trying to take away that decision-making that the nephrologist is not comfortable with. I used to work in Detroit, and we had a nephrologist that when kidneys were failing, she had a palliative care professional that met with these people to kind of give an informational approach like you described, and it was to protect her. She really felt that she was vested with these people, and it was just too much to offer a recommendation or like. So I think this work is fabulous, and thank you for presenting it, and I can't wait to follow it.
Oh, thank you. Yeah, thanks so much. I mean, I think that, like you said, I think that the conservative management pathways and conservative management clinics are becoming very slowly more integrated in nephrology. And I think, to your point, I really see it as a win-win. It's so hard for nephrologists with their really long-standing relationships sometimes to have those conversations, and it's very helpful to train them and also to help patients kind of become more involved. Yeah, thanks.
And I'll take a minute to open it up for any questions from our remote sites. And barring that, any last questions here?
Thank you very much. Great talk. I'm a geriatrician and palliative care physician. I was wondering, in terms of informed decision making, how much and then how you deliver the option of withdrawal from dialysis. Would you mind sharing that?
Yeah, it's a really good question. I think it's a very different kind of decision, honestly. I think, the focus here in this decision is that there's so much uncertainty and potential for a time horizon. With withdrawal decisions, I think we really know, what the time horizon and what withdrawal looks like. I almost feel that with withdrawal decisions, a much more traditional shared decision-making model works because you have a very defined decision point. You have a clear trajectory if you stay or if you withdraw. You've got a week to 11 days or something like that on average. I think your point is a good one, which is kind of what can we do to help people around withdrawal decisions. And I have to say, we haven't spent a whole lot of time thinking about that yet, but it's on our radar. I think right now we're really focused on trying to adapt a shared decision-making model and understand what it means for decisions with high uncertainty and long trajectories. But this question around withdrawal is very important. And maybe there are spillover effects with nephrologists kind of becoming more confident and comfortable talking about care management and supportive services. It may bleed over right into how they talk about withdrawal and being more comfortable and also having the relationships with palliative care and with other services to have better decisions around that. That's what we can hope. Yeah.
All right, we'll end there. Thank you so much.
Yeah, thanks so much.